discussed about soft cataract. We go to the extreme of it, management of a brown cataract by Dr. Rohitha.
Good evening, everyone. It's good to see all of them here, even at this, when the topic is ending.
Which hall is that?
Hard cataract.
I see. I'll still go. What is the hard?
Hard cataract. I shall just talk on how to manage brown cataracts. In view of time, I think I'll just skip to the phaco part rather than for any surgery, for a good outcome, the process has to start preoperatively. A good specular microscope is required to know the status of the cornea, and a thorough retinal examination needs to be done. Yeah. Achieving accurate biometry is difficult with dense brown cataracts, and in these kind of cases, Argos can help us because it has a enhanced retinal visualization mode where it can even penetrate through hard cataracts. The preoperative planning, that is, you have to explain the condition to the patient and explain that the surgical duration may be prolonged and the possible need of converting the case, and the recovery can be prolonged. Coming to the surgical steps. The need of tryptophan blue because the glow is not adequate is very important, and it is better to aim for a little larger axis rather than a smaller axis. In these cases, we have to remember that it is always better to do a gentle hydrodissection in multiple planes rather than just trying to do it from one corner. What happens is when you send a wave of fluid, the intralenticular pressure increases, and if you keep doing it, you may have a PCR. So gentle hydrodissection, the moment you see that the AC is slightly shallowed, you know that you have done a good hydrodissection. Avoid vigorous rotation, because in brown cataracts, because of the heavy nucleus, the zonules are already stressed. And using a Ashenov soft shell technique is of prime importance in these kind of cases. It is always better to use a dispersive visco like a viscoat initially to coat the endothelium, and then HPMC in the second place. And you can also give a little bit of BSS just above the area of rexis, because there is a lot of heat generation when you are actually doing a phaco. So it is better to have these three. It's called a tri-soft shell technique. Now let us understand the opponent here. We have a very hard nuclear core. We have a leathery posterior plate, and we have associated zonulopathy. There are three main problems we are going to face. And how do we get a perfect chop? The problem is getting a deep chop. If you are trying to engage the central core of the nucleus first, which is the most hardest part of the nucleus, you may not get a complete chop. So it is always better, and we always need excessive force to divide this. And we will also weaken the zonules in trying to do all these things.
Coming, sir,
coming. And it is always better to do something called a flower petal pattern, where you can do a peripheral chops. And you isolate the central core of the nucleus and then eat up that part.
So if you look at, can you show me the, yeah. So you see the shape of the lens, right? It's like an onion. So the superficial fibers, if you follow it all around the equator, goes back, and finally, actually it is the posterior plate. So what is the most difficult part to chop in a hard cataract? The posterior plate, no? And also the center, which is very, very hard. Now, if you imagine this is the cataract, it's a brown-black cataract. What is easier to chop, the superficial or the center? Superficial, right? So we have been always taught that, look, oh, hard cataract, you have to do a nice deep chop and then separate it. Actually, you should not do that. You should do only a superficial chop. And then when you separate it, the separation will start from the mid-periphery, then go to the equator, go down and separate the posterior plate, leaving the central nucleus behind. So once you do this, you don't have to apply so much force and struggle to separate the hardest part of the lens, but separate the easiest part of the lens, right? And for soft cataract, any guesses? Should you chop deep or superficial? Deep, because there you want to hold the hardest part, because most of it is soft. So you should be in the deep, in the center. Here, you can just be in the superficial area, that's more than enough, and automatically your posterior plate gets separated, and it's very, very easy. Please.
And we can do a superficial chop because even the superior fibers are also very dense. So your hold will be good even if you are holding it superficially. So due to the increased density of the lens, the hold is good even if you are in the superficial area, and it will have less stress on those zonules, and it will isolate the central nucleus core. Now coming to the length of the chops, like whether you want to have a very short length of the chop or very long length. So what is the problem with having a long chop? Like you can hold and you're trying to come from there to here. So you will see that your nucleus is slipping from your hand. You're seeing that. There's a tendency to rotate is more when you're trying to do a long chop. It is always better to do a short and swift chop. It is always better to just lift the nucleus when you're chopping. Me-loop can also be used, and the safe emulsifying strategy is the level of emulsification. I think we have spoken about this, that when the piece is emulsified within the bag and your aspiration flow rate is higher and you're thinking it's a hard cataract and you have kept your vacuum high, so you'll see that the PC is trying to come and hit the probe. So emulsification should always be at the level of iris, provided that you have coated your endothelium. Coming to the main thing, that's the settings. So for chop, we can see that your IP should be off, and you can keep your vacuum and aspiration flow rate at a higher rate itself. And for quad mode, your IP should always be on. That is, you can keep the torsional to 100, but you keep a small amount of longitudinal phaco remaining, so that if the phaco probe is blocked, occluded completely, it is not going to do anything even if you are in phaco 3. It will just give a jackhammer effect. It will give that small longitudinal burst, and it will dislodge the piece from the phaco probe, so you'll be able to catch hold of it again. In Centurion, you have something called active sentry. So it always keeps sensing the intraocular pressure inside the eye, and you'll have a maintained chamber. If you want to do phaco with low IOP, so when you're trying to do a phaco with low IOP setting, we have to keep 3 things in right, the vacuum rise. Vacuum rise has to be 0. That is the amount of time taken for the vacuum to build up the moment you have touched on the probe. And IOP ramp. IOP ramp is the time taken for the IOP to build up inside the eye. So you keep it fast. If you go back and see, it will be around 1.2 in your settings. So you keep it fast. And the irrigation factor. Irrigation factor is the amount of time the fluid takes to come inside. So that also has to be faster if you want to operate with low IOP settings. So here I am operating a hard brown NS5 cataract. Use of Trypan blue is mandatory in these kind of cases. A good 5.5 to 5 mm rexis and a gentle hydrodissection. You can see the wave passing. Just tap it from the other side so that you are not building the intralenticular pressure. This is the customized, it's actually a dialer, it's not a chopper. Okay, coming to the tip exposure. Here it's always better to keep the tip exposed a little longer so that you have a better hold. And how to achieve a perfect chop with 3 steps. So I'll show that in slow motion. Superficial embedding of the phaco probe first. Then you do a short chop. Try to separate and go multi-level. Go again. Embed the nucleus again and chop. So superficial embedding of the phaco probe, short chop and multi-level chopping. You will get a clean cut only peripheral. And keep repeating this at least 6 to 8 times, so that you have 6 to 8 small pieces. Then I remove the chopper, second instrument, and you can see that the central core is separated. When you take out the second instrument, the chamber is well formed. And the care continues even in the post-operative period, where it may require a prolonged course of steroids. Thank you.